Hello, everybody. Welcome back to Design for Health. I'm Dr. Kara Bobinet, along with my co-instructor, Dr. Larry Chu. We welcome you back. And we are really excited to today have our facilitator, Katie McCurdy. Katie McCurdy is a user experience designer and researcher on a mission to empower patients and improve healthcare. She's also a patient with 20 years experience with the autoimmune disease myasthenia gravis. She's especially interested in incorporating the patient voice and narrative into design. And she's been using data visualization to help simplify the complex and promote behavior change. She holds a Master's of Science in Information with a specialization in human-computer interaction from the University of Michigan School of Information and now lives in Burlington, Vermont. Let's welcome Katie McCurdy.
If you are joining us for the first time, a quick reminder that there is a simultaneous conversation happening on Twitter right now using the hashtag MedX. Katie McCurdy is the in-class moderator for today's program and will be taking questions from social media. So please make sure to start up your Twitter client to join in the online conversation and interact with today's speakers. Christopher Snyder, otherwise known as I Am Spartacus, is moderating the online tweet chat discussion this evening. We also wish to remind you that registration for Medicine X 2014 is now open. Don't miss the year's premier patient-centered conference on emerging technology and medicine. Unique opportunities such as our masterclass program and our IDEO Design Challenge workshop have extremely limited space availability. Regular registration rates are now open until July 1st, 2014. Please also make sure to like our Facebook page at www.facebook.com/StanfordMedX. Please note you are watching a live online program and there is a delay between real-time events and the live stream you are watching. Tweets from our in-class guests will appear before you see the real-time events they are tweeting about unfold on the video live stream.
Hi, I'm really excited to be here today, and I would like to tell you a story about how I solved a communication problem for myself as a patient using my design skills. So I will start at the beginning. When I was 13, I was sitting at my family's dinner table laughing at something my brother had said when my mom looked at me and said, "Why are you making that face?" I said, "What face?" I ran to the bathroom and looked in the mirror, and I tried to smile at myself, but it just looked like a grimace. So soon after that, I was diagnosed with the autoimmune disease myasthenia gravis, which causes weakness. For me, it affects mostly my facial muscles. So I'll have a weak smile, I'll get double vision, a droopy eyelid. Sometimes my voice gets tired when I talk for a while, so if that happens, I might need a break. So over the years, I've taken a lot of different medications and immunosuppressants to try and deal with my symptoms. And over the years, my symptoms have become kind of a very confusing cluster, might be a little hard to see here, way beyond just weakness from myasthenia gravis. And especially, I had experienced problems with my guts, bad guts. And 2 years ago, I decided to go see a new doctor to try and address this. And I realized I had no idea where to even start telling him my very long, confusing medical history. So I decided, I'm a user experience designer, and that's my job. And as part of my job, I make things easier to understand, and I simplify the complex. And I decided that the best way to tell my story would be to create a timeline. So I started on paper and actually created 2 timelines, one of my myasthenia gravis weakness symptoms and one of my bad gut symptoms. And the timelines were from birth until today. And I indicated high on the y-axis when I was feeling good and low on the y-axis when I was feeling bad. And I made notes about times when I started or stopped medications, when I got bitten by a spider, how I was diagnosed. So anything that I thought would help my doctor kind of understand my story. So the next thing I did, excuse me, I'll keep talking. The next thing I did was put my timelines into a graphics program And that's coming up. And I used a peach color to indicate bad guts and a blue color to indicate weakness. And I overlaid the two timelines on top of each other so I could see how they related to each other. I printed them out and kind of got ready for my doctor visit. And I was feeling really excited and hopeful that this would help me tell my story. So when I got into the doctor visit, I laid the timeline down on the table and used my finger to kind of talk through the highs and the lows and really explain what had happened with me. And in this first doctor visit, the doctor was maybe a little skeptical of me bringing this graph to him. I was a little bummed. He kind of kept his distance, but I found that for me, this was a really great storytelling prop, and it really helped me tell my story. I found that I was able to be more coherent and organized in my thoughts, and I could really remember everything that I had wanted to say. And so after that point, I took the timeline around to a bunch of other doctors, and I brought it either on my iPad or on paper, and they loved it. My neurologist said, "You go, girl." So I was really happy that this was a good tool for my other doctors to especially understand how I was diagnosed, so I didn't have to have repeat testing done. So overall, I felt kind of more in control. I could see my symptoms. I could understand what had happened to me. I had a better grasp on my history. I also changed my behavior and stopped asking for antibiotics, which I had been asking for to help with my gut issues, after I could kind of see on my graph that they only helped me for a short period of time, after which things would get really bad again. So you can see how this was sort of a design process where I identified a problem, prototyped a solution, and brought it to my end user, which was my doctor. So it was successful for me, and I hope that kind of my call to action is for us to co-design with patients so we can help solve their real problems. Thank you. So I'm going to introduce Nick Dawson, and we're going to be co-presenting together. So Nick has more than 15 years experience in working in hospitals in strategy and operational roles. Today he's focused on helping health systems develop a modern strategic focus based on human-centered design. He's the president-elect for the Society of Participatory Medicine and previously worked for Augusta Health and Bon Secours, Virginia Health System. Nick holds a Master of Hospital Administration from the University of Minnesota. He's a member of the American College of Healthcare Executives and lives in Richmond, Virginia.
Time to take another shout out to Twitter. If you are following this conversation online or on Twitter, Christopher Snyder, otherwise known as I Am Spartacus, is moderating the Twitter discussion on the MedX hashtag. If you are just joining us, we have with us today Nick Dawson, President-elect of the Society for Participatory Medicine, on the topic co-design, bringing the users into the process. E-patient moderator and speaker Katie McCurdy is also with us today. Please make sure to like our Facebook page at the program, and there is a delay between real-time events and the live stream you are watching. Tweets from our in-class guests will appear before you see the real-time events they are tweeting about unfold on the video live stream.
Well, welcome back to our live audience, and to the folks in the room. Hello, it's nice to see you all. Just maybe as a quick start, give me a show of hands of who you are. Who is a student here? So a lot of you guys are students. Who is a physician already, or a provider, or a nurse practitioner? And what are you guys, physicians or
Plastic surgeon.
plastic surgeon? Ma'am?
I'm a retired physician.
Retired physician and a plastic surgeon here in the room. How about designers? Is anybody here a designer as their primary role? We've got a couple designers in the room. And I know we've got some folks on Twitter too. And so one of the things that I'm going to try very hard tonight is to be in two places at once. So we're going to keep an eye on the Twitter conversation, and as we pose some questions to the group here tonight, we're going to ask the folks online to think and respond the same way, and we're going to try to make that a very integrated process. So bear with me as we give that a shot. I'm going to actually try my best after a little bit of a preamble here to not talk very much tonight and let Katie spend most of our time together tonight leading the discussion. And that's because I'm not a designer, and I'm not a physician. I'm not a provider as a primary identity. I've never been a med student. And so I feel very, maybe like the least qualified person in the room tonight. My background is, as you heard, in hospital administration primarily. And so for those of you who will become doctors, that you can think of me as kind of like the Darth Vader figure. For everybody else, it's more like just a stormtrooper. I'm the guy that was just in the suit that literally provided no value and kind of just walked around. And I want to share maybe, since I'm not a designer and I'm not a provider, and I'm not always somebody who identifies primarily as a patient, some of the cultural things that I've picked up and some of the experiences that I've had, and some places specifically where I wish in my career that I had employed co-design sooner, that I had known about some of these things, that somebody had taught me in my graduate education about them, and some examples of where I've used some co-design and been part of groups that have used it. So we'll jump right in here. So this will be our first interactive piece of the night. What is co-design? You've gotten a sense of it. You know why you're here. You've been through, 4 classes so far. Twitter folks want your thoughts on this as well. What's co-design? This room just got very quiet. What do you think? What's the root of the word? What's design? What have you learned so far? This is not for a grade, and you've already been fed, right? So there's no penalty. Anybody?
It's involving multiple stakeholders in the design process.
Thank you, Richard. Yeah, exactly, involving multiple stakeholders. So who are examples of those stakeholders?
Patients, all the people that you had identified earlier, a lot of different kinds of folks.
Yeah. So we're going to, actually, I'll let Katie. Katie, why don't you give a little more formal definition from your design perspective?
Okay, sure,
Trade places with me, too.
We'll trade. Thank you. So co-design in healthcare is kind of what we want to focus on tonight, and you talked about co-designing with children. There's a lot of different types of co-design, and we're going to kind of be thinking in the mind space of healthcare tonight. But co-design is really, just like you said, a way of bringing end users into the design process, and a lot of times that's happening in a workshop format, so in a format where it's really interactive and you're kind of doing physical activities and being creative. The kind of root of co-design, you'll also hear participatory design as a term. The root of it is in Scandinavia in the 70s. They used it as a way to bring community members in for the design of things like parks or public spaces to really kind of participate and bring the community voice into the process. So co-design really assumes that users are experts of their own domain. So the user is the expert. So why wouldn't we want to design with an expert? If we're designing something for them, why don't we involve them? So it's really sort of it encourages this sort of blurring of the role between the end user and the person who is kind of designing for that end user. So instead of designing for the user, you're designing with that user, that person. So it's sort of an ideology or philosophy or sort of a political stance that you're giving up a little bit of power to your users by involving them in your design process.
Katie, I'm just reminded, of course, that we have a little bit of a delay between our live video, so the Twitter audience is now chiming in with their versions. So can I read a couple real quick?
Sure.
Yeah. So I like these. These are very simple and they're very clear. Alan Brewington says, it's when patients, doctors, and healthcare providers come together to solve or improve healthcare. Annette McKinnon says, co-design means to me that the end users are involved in creating the design. So that seems pretty consistent with what you just said.
Awesome. Right on. Great. And we talked just quickly about who are the end users in healthcare. As we all know, end users of any product are diverse. So we're talking way beyond patients, even though Nick and I have a special interest in bringing patients into a design process. but caregivers, support network, providers, even lab techs, all of these people are part of our healthcare system and could potentially be end users.
I'm curious. Go back.
Yeah.
Katie and I, the only plan we had is that we would promise to interrupt each other and kind of tag team this. So, who is left off this list? Who's a stakeholder in healthcare that we've not thought of?
Insurance companies.
Yeah.
Insurance companies.
The payers.
Regulators.
Regulators.
Which would include FDA, policymakers. We could talk about the government in a whole bunch of ways. Yeah. Those are great. What else? Pharmaceutical companies, yeah.
Absolutely. Thank you. So what do we mean by design? And I think you all have had sort of a great intro in this design course. And so what sort of things are designed in healthcare? And maybe if someone could just pipe up with a thought. What things are we designing?
Medication carts.
Medication carts. Mm-hmm. Okay. What else? Yep. Waiting rooms. Great example. Mm-hmm. Packaging and instructions. Yep. So you talked about a couple things and a place. There's also kind of services and systems, so things that are actually invisible. So the experience that you have when you go to a doctor, so from start to finish, what is that flow like? Policies and laws, we talked about government. So there's a lot in healthcare that's actually invisible but still needs to be designed, and a lot of opportunity to bring end users into that design process. So why would we use co-design? Annie was here and Dennis from IDEO talking about building empathy and a few methodologies for doing that, like observing users or interviewing them. So why is co-design different, or how is it different? When we talk about a workshop format and going through kind of creative activities with people, it can be a way of researching, kind of finding out how someone feels about a topic that might be difficult for them to talk about. An emotionally difficult or emotionally charged topic can be a way for people to express themselves in sort of another way and not have to open up to someone completely in an interview to someone who might be a stranger. Also, there are certain things that are just kind of needs and underlying kind of deep-seated mindsets and mental models that are difficult to articulate. And when you go through these exercises with people, it's a way of kind of drawing out those kind of deep feelings. And then, Nick, do you want to talk about affecting culture quickly?
Yeah. And that I'm going to delve into this a little more when we tag team examples, but to me that's the very salient piece, at least from my perspective. So when you think about the way healthcare is delivered, and it's primarily through large health systems or through your doctor's office or through hospitals, what do you think of when you think of that culture? Maybe I'll even back up. For those of you that are students right now, what has your experience been like as a student? What's valued as physicians? This is a hard one. It requires a little maybe introspection. I think I just made up a word. So what do we know about healthcare culture?
It seems pretty resistant to change.
Yeah, I think that's fair. Resistant to change. Why? Any thoughts? Liability, yeah. How about back? Yeah. Yep.
I think part of it is also this idea that the doctor knows all. So challenging the doctor, like going to another physician, or like bringing up an idea on the part of the patient is sometimes seen as like almost a violation of that relationship with the doctor kind of comes into view.
So that, and I want to try to repeat it and make sure I got it. So the idea that the doctor knows all and that challenging that relationship is kind of antithetical to the way we built the whole system. Did I sum it up right? Hold that idea, because I want to come back to that. I think you're onto something there. I think that we've inherited a culture that we didn't intend to inherit, that's around that idea of one person having the right answer all the time and not being challenged. So that's, when we talk about culture, that's kind of one of the things we want to think about.
A few other points here. This is another means of building empathy. So we're using co-design to kind of understand build a mutual understanding. Also to make sure we're solving the right problems, and this is so important. A lot of times we'll sort of make assumptions about what people's problems are or what their needs are, and we'll build products or experiences or policies around our assumptions. And when we use techniques like co-design to bring people into our design problem or our design process, it's a way for us to ensure that we're really creating the right foundation and we're building solutions on top of real human problems and not just our assumptions. So kind of intended outcomes, most importantly, is a shared understanding and mutual empathy, which I talked about. If it's a workshop type of co-design situation, there's also these visual, tangible artifacts. So things you can hold, things you can take back with you and share with your larger team, things that can serve as inspiration for months or years to come because you'll have them to refer to and you can put them up on the wall. So what does it look like? We've been doing a lot of Q&A, so maybe we'll keep moving forward. But so what does it look like? We've talked a lot about workshops and creative activities, and that is definitely a prominent form of co-design. I think Nick and I would also like to bring another or a broader definition of really inviting your end users to the table. So giving them a seat at the table, giving them a voice. It's sort of like a philosophical and a political approach, giving up a little bit of power and bringing people in. So.
I like that picture, by the way.
Yeah.
That's your stuffed animals at the table, right?
Yeah, exactly.
We're trading places here.
Yeah.
Yeah.
Go on.
So I asked you to hold that idea that I love, and thank you for volunteering it. And I like your idea too about regulations and liability, and so there's some fear of risk. Or risk of failure and a lot of fear associated. And I think there's this culture that I keep alluding to, right? And that's a little bit of a nebulous concept, but you probably have a sense of that if you've ever been on the receiving end of care, right? That it's often kind of a father knows best attitude. And thankfully that's changing. I don't think that, in fact, let me take a moment and pause. The fact that this is part of your curriculum, I think, is a big sign that there's a big culture shift underway. But we got to remember too that a lot of that culture was built by people who went through their training 50 years ago. And so we've inherited some things that we're working on changing. My term for this, and remember I'm not a designer, so forgive me, is design by assumption. I called it assumptive design. And I'm going to give you some examples of what I mean. But as a really bad generalization, the way that a lot of things inside hospitals end up happening are that somebody says, we need to do this. We need to do something. I'm going to, as an executive, assign it to an individual or a team. And when that person's done, they're going to have had the right answer, and we'll all pat ourselves on the back. And that's the way a lot of things happen. And I'll give you an example in my career. I was asked to be part of a team that was charged internally with designing a patient-friendly bill. That was actually a pause for a joke, right? The whole idea of a bill being patient-friendly might be a little bit funny, but it's late. I had a lot of coffee, by the way. So, and so we sat around for 6 months, and we looked at all of these examples. We pulled our cable bills from home, and we started bringing in cell phone bills. We said, what do we like? What don't we like? What would us, in our dark suits, in our fancy conference rooms, what do we think patients would most want to see in a bill? Well, we should take the words charges out. And what is an EOB? An EOB is an explanation of benefits, and that's complicated language, and most people probably can't understand that. So we made these assumptions, right? And by the way, I'll just take a quick pause. This is, I love this. I did a little Google search through my notes and found this from the archives of a health system I used to work for. This is a bill that shows for one night stay, for the daytime, it was $12.50 a day, $12.50. That's not $1,250. And for the nighttime, it was $1.50. That included nursing care, by the way. We've kind of changed our healthcare billing practices a little bit. So we came up with this what we thought was going to be a great patient-friendly bill. It was not this. Arguably, that's a pretty good-looking bill. You'd understand that pretty clearly, wouldn't you? It looks like a tab from a restaurant. And these things have a bit of a lag. So within about a month, we started getting phone calls from patients who told us, I'm used to seeing the phrase explanation of benefits. I know what that means. I'm not an idiot. Why is that not on my bill? Do you really want me to pay this, or is this just something you're mailing me and I'm supposed to wait for a bill? So the result was we stopped getting paid as quickly as we'd been used to getting paid. And if you think about hospital culture that I've been alluded to, as soon as the money stops rolling in, people pop their heads up pretty quickly. So we did this great job of assumptive design. We thought we had come up with something that, that patients were going to love. And in the reality was we had dumbed it down and made some really bad assumptions and probably cost ourselves a little bit of money in the end. The good news is they were willing to tell us what they thought. And if we had invited that work in, if we had invited those comments in from the very beginning, I think we wouldn't have had that little short period of creating something that was not satisfying. So that was an example of failure. How's that for leading off with what doesn't work? A slightly different example was something that did work. So we had a program where we said we want to work with some of our physicians, and this is not real data, but it is the app we used. So think of it as a visual here. We wanted to go to these physicians. We said our goal as a working team is to reduce cost and improve quality. That's probably a phrase you've heard quite a bit, right? That's like the thing being discussed in American healthcare right now. How do we improve quality and reduce cost? So we said to this group of physicians, help us figure out what that looks like, because the way we would normally do that is what? I mean, is a carrot and stick approach, right? So we would say, oh, maybe the physicians who hit certain targets get a bonus and the ones who don't get penalized. They all told us, don't do that. That doesn't work. We don't respond well to that. So think about, and maybe in your training, what would work? What do we know about physicians? What do we know about their lives? A lot of time in the day, sitting around doing nothing? Is that true for you as students? A lot of free time? So what do we know? Busy? It's not a trick question. I didn't mean it to be. Very, very busy, right? Hard to get things in front of them. Not a lot of, especially for those of you who are in the room who are physicians. Is that true? Is that a fair statement? I'm up here making assumptions about you guys. Tell me if I'm wrong. We found out that it had to be something we could get in front of them very quickly and very easy to digest. Is that true as well? What a lot of them told us was it needs to be almost like a lab value, something that I can look at. So we said, all right, would it help us if we pushed information to you? Yeah, absolutely. What kind of information would help you think about cost in your day-to-day job? So what do you think they told us? Think back to, I want to use your example again. What do we know about that culture? Yeah, what's your thought right here in the second, in the gray?
That maybe they didn't need it. They didn't need an extra thing to help think about cost. They could take care of it themselves.
Fortunately, this group agreed that they were willing to care about it. So they may have thought they didn't need it, but they were willing to go along with it. Yeah. What do you think would help move that needle? What one data point? Any thoughts?
I heard something that that a lot of doctors don't get the cost of the labs they order.
Yep.
So just giving them that data would help them.
So that's exactly it. It was showing them the data, the cost of the stuff they were doing with one extra piece relative to their peers. So that was the thing that really drove it over the edge. So they told us, we're really competitive. If you can make this a game, then we will change. They told it. So what we did is we found this mobile app that allowed us to take data and push it. And what we pushed to them was a bell curve, a little slice of a pie that looked like this. So we would say, by the way, compared to your peers, your cost is that big orange slice or that big red slice. And that was something that we would never have gotten to if we hadn't involved them in the process. So that was an example of not following a design process per se, but at least involving the end user. Turn it back over to you.
Yeah, sure. So I'm going to talk through an example, one of my favorite examples of co-design. A few years ago, I was working, actually last year, on a project to help patients visualize their symptoms. Obviously, that's an interest of mine. And I was working with a startup who wanted to help patients visualize symptoms on a 3D avatar, so a 3D body. And we kind of got into the project and realized that we weren't quite sure how patients would naturally visualize their symptoms, or how do patients see their symptoms. And as a patient, as a patient and sort of dabbler in communicating about my symptoms, I had come up with a few sort of symptom bodies over the years, things that I had created and sort of sketched my symptoms on a body and shared with my doctors as a way to communicate what was going on with me. So I had a certain way of doing it. I used color a certain way. I used textures a certain way. But I wasn't sure if other patients would use the same method that I used. So I knew that I wasn't potentially a representative patient. I know I'm a little weird. So I wanted to find out what other patients thought. And so we started the process with some research questions, and that's something that's actually a really important part of this process, is making sure that we're really clear about what we're trying to find out, because that actually helps us kind of target the questions we're asking people and target the activities that we're asking them to do. So we really wanted to know what's currently difficult in your life. Like, why is it difficult to communicate about your symptoms, or is it difficult? Are we just assuming it's difficult? What's good and bad about communicating about symptoms? And then also, what colors and shapes would you as a patient use to communicate your symptoms on this body shape? So these workshops are actually pretty labor intensive, but it's totally worth the trouble. I recruited some patients from sort of my extended social network, 2 with autoimmune diseases, not the same as mine, 1 with diabetes, 1 with a very acute ankle injury, which was healed, partly healed. But anyway, so the next thing to do is I bought a bunch of different art supplies, which is probably one of the more fun things to do. So glitter glue, markers, crayons, little puffy balls, just anything I could think of to help people express any sort of bodily sensation. So I put together incentives. I really believe strongly in paying people for their time, especially patients. Made sure I ordered food, prepared video for the session. So basically it was just taking care of all the tiny details for the session. And the basic, well, let me go into it. So the first thing we did was actually a primer discussion, or it's also called preconditioning. Basically, it's either an exercise or a discussion to really get people in kind of thinking on this topic and bring their minds to this activity. So in this case, we had a discussion as a small group about what is currently difficult about communicating symptoms. How do they prepare for a doctor appointment? What do they do? Do they bring notes? How do they do it currently? And just trying to get at what the problems are. Yeah. So the exercise was they were given body outlines, either the outline of a body or a 3D avatar with all the muscles and the bones. And then they were just supposed to create a representation of their symptoms. And we actually found out some really interesting insights. So I found that patients tended to use color to represent the quality or severity of their symptom, which, kind of makes sense. If something's burning, it might be red, or if it's very sharp, maybe it's a stronger color. And this was a great insight for me because I had been using color more to differentiate between symptoms. So like, headache is blue and burning fingers are pink or something like that. So color was used to indicate severity more than to differentiate. Also, shapes were used to represent symptom quality. So like a spiky, sharp shape would be a sharp pain, and a more round shape would be more of a kind of a dull pain, which was an awesome insight for us. Non-physical symptoms were really interesting. We didn't quite expect this. People on the left, this person wrote stress of persistent pain management and made a little cap on their head. And the person on the right has a kind of a cloud around the head, which looks like hair, but it's actually brain fog, a symptom of her autoimmune disease. So we kind of absorbed the findings from this exercise and brought it back. And this is now sort of an outdated comp of the app that we're working on to help people express their symptoms. But this process was just really enlightening for our team and has been sort of, we've gone back to the video a few times, and we definitely have referred to the paper artifacts a number of times through the process. So.
We tag team again?
Yeah.
Oh, awesome. I want to take a step back because I'm not sure. I've been not paying attention to my notes, but I have been paying attention to Twitter. where Chris points out that I'm asking a lot of rhetorical questions. So here's another one. Katie, when I look at that, I would think there would be relevance in clinical notes. So if a patient came in and said, this is a picture of my pain, to put that into and so my question is, does that make sense? Is there a reason that we don't do that? I think physical therapists do it, right? They always do show me, there's a picture you fill out in a worksheet. Does anybody think it wouldn't be helpful as a physician? You have a lot of data already, right? Looking at, pardon? Yeah. So I also want to take a quick step back and just say, if I've used some language, it sounds like I'm singling out physicians when I talk about culture. I don't mean to. What I meant to say is, and I want to make sure I clarify this, that we've inherited in how we've structured all of healthcare delivery that idea that somebody should have an idea, that somebody should have the right solution every time, and that's the way that at least me and my administrative colleagues have often operated. So I apologize if it sounds like I've picked on anybody, because I don't mean it that way. This is a quick anecdote. I had an opportunity at one of the health systems I worked for to be responsible for several of our urgent care centers. So you probably know that urgent care is kind of that step between your primary care physician and the emergency room, where people walk in without an appointment. And I didn't have an office at any of our urgent care centers, but I thought it was probably an important place to spend my time, so I would kind of set up with my laptop or iPhone or whatever in the waiting rooms and just kind of work and observe and probably be in the way more often than not. And one day, a elderly woman came in and was sitting in the waiting room, and one of our nurses came out and said, I'm seeing from your intake sheet, from your symptoms, we can't treat you here. We really think you should go to the emergency room. And she grabbed the nurse's arm and began bawling and said, please don't make me go there. And I think some folks may have heard me tell this anecdote before, but she said, I've been there before. I know what they will do in terms of tests. I know it's not what I need. I know you can give it to me here. She was really detailed, knew enough about her condition and her symptoms. And I'll kind of protect what that is, but trust me when I say that we could have done it there. And she said, don't make me go there. And ended up spending the rest of the afternoon with us, having a treatment, and then telling everybody who cared to listen, and I mean that because people would come into her room and ask again her story. And she was a 3-time cancer survivor. That was not why she was there that day. It's something she freely divulged. She had started the local support group for her particular cancer diagnosis. This was somebody who didn't know the word e-patient, but was way, way high on the activation scale, really, really powerful, and could speak to things very eloquently. So we, my team, my urgent care team, we did a design charrette one day where we met at night and we said, how might we improve the patient experience? Pretty broad question to go after, right? And we invited her to come and be a part of the team. And we did a little bit like what we're doing tonight. She spoke at first, and then she sat with us the whole night as a patient. And Katie, I like your phrasing you used earlier, because she became the expert. Everybody in the room, from the nurses to the doctors to me and the managers and the administrative staff, almost needed her validation. She was the one who could tell us if this would work or not. And obviously a very small sample, right? A sample of one. But I could tell that, because she told us afterwards, how much she valued being involved, that her whole healthcare experience had been done to her, and this was the first time somebody had said, help us make it better. So we came up with this slogan. This actually came out of that night. We had T-shirts made and buttons made, and this became part of our culture at our urgent care centers, where we said, together we can make it better. And that meant in your treatment plan, you have parity as a patient with the providers. You can help us make you better from a design, experience design standpoint. So we tried to make that thing that happened with her, and then that little bit of magic that night where she became an expert with us, into part of our culture. And I think I'd like to think it was successful, but I think we really learned a lot about the power of that in-user experience that night. It was a fun thing to be a part of.
Switch off. Okay. So my last example, I'm just going to talk through really quickly.
You should high five every time you do the switch off.
Okay. My last example is from last year's Medicine X conference. I was fortunate to attend the IDEO Design Challenge, which you may have heard about in a prior session. But basically, it brings together a bunch of different people to IDEO for an entire day-long workshop. and basically the goal is to design a patient-centered solution. And I attended as a patient with a number of other patients, and as patients we were matched up with a group of very diverse people. There's me, and there's my group. And so doctors, there were like doctors, industry people, designers, a lot of different people. And the session was run sort of like a design workshop or a design studio. And as a patient, I brought a few problems to the workshop. And then during the course of the day, our group picked a problem that they cared a lot about. And in this case, it was, how might we support patients in communicating a consistent story across multiple providers? I was actually reading it from the Post-it note on the wall. And so we started with that sort of how might we statement, and then brainstormed like wild blue sky solutions related to that problem statement. And then, so the day also involved kind of prototyping solutions and then sharing out feedback. And a really important, actually, part of this day was the first step, empathy storytelling, in which I, as the patient, was treated as the expert. And it was actually very similar to the story Nick just told about the woman kind of taking part in the design. So basically, a lot of times, everyone was kind of staring at me, and I have a good slide about that in a minute. But it just involved a lot of question asking on the part of the other group members, and a lot of talking on my part. Our prototype was a hilarious video, which unfortunately doesn't have the video is not very, or the audio is not good enough for me to share it with you. But so that was our form of prototyping a solution and sharing it out with the group.
Can we tweet the link later?
Oh yeah, sure.
We'll find a way to get it out.
Yeah,
We
sure.
need to see it.
Yep. And what was amazing about this day is sort of, I think this day was designed so that each small group would sort of build empathy with the patient. So it was meant to be a patient-centered design process. And you can see in this picture I'm talking and everyone's laser eyes are looking at me. But what happened, I felt, was we really kind of created a mutual empathy. So I understood better what doctors face in their day-to-day work. The doctors both kind of put their heads together on what they were facing. So this sort of very interdisciplinary workshop just helped everyone on the team, and I'm sure you've found this in a lot of different situations, helped everyone on the team really understand each other's perspective much better. So with that, we are going to take not very long, like maybe 20, 30 seconds, and I just want you to think of, and if you're out there, tweet it, think of a way you could bring co-design into your life, into your work, into your school. I know you can do it. So think about it, and we're going to ask for just a few examples. And then we'll do Q&A.
So we've tweeted that question too, so maybe we'll beat the video lag a little bit, but just to kind of keep our Twitter audience engaged, we want to make sure we're asking you the same question. I'm also buying time so they can write a little bit.
Nice.
Or we could do a song and dance.
This is our song and dance.
So let's take maybe 15 seconds, turn around, and can you tell people about your jacket?
Yeah, I wanted to explain about my jacket. So this is painted by the artist Regina Holiday, and I think when Richard spoke a few weeks ago, I think he was also wearing his jacket. And she's an artist who has a very moving story. She lost her husband a few years ago, and she now paints the people's patient stories on jackets. And the point is for people to wear the jackets at healthcare events. A lot of times there's healthcare conferences where everyone's wearing a black suit and everyone kind of looks the same. And this is her sort of installation. It's a walking gallery is what she calls it, so that people will come up and it invites people to share their stories more freely, their patient stories. Yep.
Well, great. So that was our Instead of Jeopardy theme. We had
Yeah.
our little jacket interlude. So
Yeah.
back to our question, and we're going to look at the Twitter examples as well. What are your thoughts? How could you integrate co-design?
So I think it's important to bring users in at every stage. I mean, even when you're brainstorming the product idea, like if you bring users in and none of them seem excited about it, it might not be worth doing in the first place.
So Max, I'm going to ask you to repeat that since you've got the mic now.
Sure. So I was saying that you should bring users in at every stage. A lot of people just bring them in at a beta stage near the end. I think if you bring them in from the very beginning, even in those initial brainstorms, it can save you a lot of headaches down the line and maybe a lot of cost too, because if you bring users in and they're not excited at the beginning, they're probably not going to be excited at the end either.
I love that. That's a really pragmatic reason, right? Bring them in early because it'll save you time and cost. In the end, you'll get a better result, right? I'll read a quick one online. Neil Ulrich says, as a design student, get outside the classroom, break the bubble, and change our assumptions. That's his example of integrating co-design. What else? What other thoughts do you have? Yeah. We could like throw you the microphone. Well, we're passing it back to you. We'll invite more Twitter comments to come in.
Bring in a variety of different people in onto the design. So people from, not necessarily everyone from the health field, and not just the patients, but people from very much outside the health field, like artists and graphic designers and things like that, because they can bring a very different perspective to your design.
So I like that you're broadening the idea of who the stakeholders are too, right? So I love the idea of bringing in artists and graphic designers. And who else? Do we have some other tip? Maybe right? Was it in the back? Was it?
Anyone have a specific example from like an example from your life, your daily life right now? Or how would you, I could turn that around as well. How would you like to be involved in a design process?
Mike's making its way.
Hi.
Yeah.
Well, I just spent from 4 to 5 with 10 to 12-year-olds trying to get them to do an ACL intervention program.
ACL?
And yeah,
Is it knee repair?
Yeah, we could not get them to pay any attention to us. They were completely uninvolved in what we were trying to get them to do, which was keep them safe. So none of us ever asked any of them what they think of the intervention or if they like it or anything like that. And had we figured out how to engage them, we would have learned early on that they don't care about injury prevention at all and just want to be better soccer players. And so as soon as we started talking about how this is going to make you jump higher or kick harder, we got them and they paid more attention. So had we involved them in our original design process, we would have known that.
So some of it was understanding their motivation. I've had 3 ACL repairs. I can just go and show my scars. That'll get them. What other thoughts? Any other specifics? Ways you could? How about from a student perspective? How could you integrate co-design into your med school experience? Surely you guys thought of a few other things. We can put you on the spot. Let's look for some more Twitter ones while you're thinking. What else?
Does anyone have any concerns or feel like co-design just wouldn't work for me for some reason? Or does anyone have any doubts about it or worries?
So online, Anita Ching speaks about she says, I want to be more creative about finding ways to involve other stakeholders and involve patients. I think that's an interesting idea, right? That's a little bit what we're trying to do now, because there's a lot of these things that are obvious maybe to some of us about patient experience. We talked about that one, maybe some process things, maybe medical. We talked about med carts and packaging design, but there are probably some things that require a little bit of creativity about how we would involve other stakeholders, whether they're patients or providers in co-design. Yeah. Let us hand you the mic and then, yeah.
In your institution, were you involved in electronic medical records?
Was I involved in?
Yeah.
At times I've been involved in rollouts, yeah.
Was there any physician input in designing the electronic medical records?
It's a wonder. I love that discussion. We could have a whole, not just one night, we could have a whole class on that, couldn't we? So in my experience, and I don't know a whole lot about this, but I can tell you what I've observed, and you tell me if this is consistent with what you all know. Physicians are often involved in helping build the way that institution will use its EMR, so building smart notes or building abbreviations, some of the codes, some of the order of the way the fields are laid out, but they never get involved in that very upstream part. They're never invited to go out to the vendors, at least not in big groups, and help co-design what does the whole user experience of this system look like? What does the ecosystem look like? How does it work on my phone versus, so they have focus groups and end user groups, and I'm talking outside of my area of expertise, but I think there's a big opportunity there that highlights for me. Thanks for mentioning EMRs. Yeah.
In response to your previous question, I think one of the biggest challenges as a student is we're always so busy, kind of as physicians are, anybody, But when we know a specific solution of how you can go about something to get to a particular endpoint, you don't necessarily have the time to incorporate everybody that you can possibly think of and just go through a systematic process of saying, oh, that idea won't work, that idea won't work. You just need like a quick solution. So I think that's probably the most difficult part with co-design.
Can we turn that to a question for Katie? Are there ways to make it a very quick?
Yeah.
Well, one thing a lot of times we talk about in design research is being fast and light and finding ways to validate things really quickly without necessarily getting really intensive and taking a lot of time. So a lot of times we'll like sketch ideas and get quick feedback or make a prototype out of paper and just like go through it really quickly, or the video probably would not be a good idea because that's probably more intensive. But there are ways of bringing people in, asking people questions, getting quick feedback when you're on the go and you just don't have time. There may be situations where it's just not the right thing to do, and you're just going to want to prototype on your own and just see how it goes. But there are sort of kind of fast and light ways of doing it, and we always try to involve people, participants who are experts in the domain area. But there's times when you could just grab someone next to you, and they don't necessarily, so a lot of times asking someone is better than asking no one.
Some of our previous speakers have talked about like bringing people who aren't necessarily stakeholders but have analogous experiences in. Is that considered co-design, or yeah? Is that like how have you guys used that?
What's an example of analogous experience?
Oh, I don't remember exact examples.
Is it like a call center representative, for instance? That's an example I'm familiar with. So if you don't have the time to bring in the people who actually call into the call center, if you can get the call center representative involved as like a subject matter expert, I think they can be a good proxy in certain cases, and that can also be a solution if you are trying to go fast and light, to bring in someone who may not be that end user, but they spend 8 hours a day talking to them, so they bring a perspective that can really be informative. Yeah.
Let's kind of broaden this as we have a few minutes left to kind of a wider Q&A. We'll invite our Twitter audience to participate. We've got just a few minutes, I think. Is that right? So what other questions? Richard?
What are some of the things which need to happen to enable co-design to happen more often and in more places?
Do you want to?
Sure.
I mean, I'm happy to. You're the expert.
Yeah, you go first. You go first.
So what needs to happen? I'll speak just specifically to that cultural piece that and I think it's this sounds really simple, but I think this is the truth. It's doing it once to have the aha moment. And once you do it, it's a little bit contagious. It's infectious, in fact, if we're going to stick to healthcare terms. So, and so it's finding something. This would be my advice to a hospital, and this is off the cuff, but I think it's true, would be finding something that you feel safe enough. This goes back to whoever at the very beginning spoke about a little bit of the fear and the risk and the liability involved. So don't pick how might we do heart surgery better, because maybe that one has a little bit more risk and complication. But you might pick something like how might we improve accessing the main entrance, and you talk about parking, and you talk about places to put your umbrella. I don't even know what those things would be, but find that simple thing and then get the exposure to it, and I think it would probably catch. Katie, do you have thoughts about?
Yeah.
On the spot right as you were
no, it's fine. No, we have another question from Twitter. So yeah, but I feel like partly it's exposure and awareness. I feel like more people are talking about participatory design as a technique. I'm just hearing a lot more about it, and we sort of have our interviews and our observation that we fall back on a lot of the time. But this is really like a fun, and I think once you've done it, you're so excited about it because it's so fun to be a part of these groups and sessions. I think it's awareness, and I think people are becoming more aware of it over time. Yeah.
How would you credit the patients with any intellectual property, or are they generally just happy to contribute to a co-design of an important product that will help that disease or condition or whatever?
That's such a good question. I said before, I feel really strongly that patients should be compensated for the time spent in sessions like these. If it's like a longer term commitment, if a patient is on a team and all of the rest of the team members have some sort of intellectual property, my instinct is that the patient should also have. We talked before the class started about bringing your own, trying to guard your own idea when you're in a group setting and the danger of that. I think it's a little dangerous to include patients equally in a design process, especially if it's a long-term kind of patient commitment, and then cut them out in that way. So.
And I don't have a lot of experience. I have none of experience actually in intellectual property, but I would echo that idea that they have to be treated with parity in every respect. Meaning there has to be compensation for the time. They have to be valued as equal members of the team. And inherent in that, I think, are some things that we're just beginning to understand. What is that parity? What does dignity look like? How do we do it, to borrow your word, without being patronizing? And some of that's going to require that cultural shift that as we do more of this, we'll start to realize, are we putting people in unfair positions or unkind positions? And I think it'll come with experience.
I just want to jump in because there might be some inventors here in the audience, very high degree of invention going on in this group. So if you do have somebody who contributes to your invention, it's actually legally obligatory to include them as a co-creator of the IP when you register it. So if they source the idea and they can prove it, in your design session, I had that idea because you're recording it or whatever, or even if they claim that, you have to make sure that you name them as an inventor on your IP.
Well, this is great. We're wrapping up. So a couple more questions or thoughts, more pushback.
I actually have a good one from Alan Brewington from Twitter. Why did the healthcare system forget about the patient in design for so long? Any thoughts?
Yeah, I have a few.
That's
but
awesome.
I think it's what we've been talking about. We did a fantastic job of building a system where think about this as an interesting design construct. If you build a system where you say you don't have to worry because somebody else is going to worry for you, in some ways you might think that you designed something really well. So we created this world where we said doctors are going to go away to school for extra number of years more than anyone else and become experts in this thing. And when you feel badly, don't worry, you can go to them and they'll take care of you. And that's the promise we've made as a society. So I don't think it was an intentional exclusion, and I don't think it was forgetting. I think it was maybe bad design from maybe the age of Hippocrates or very early. I think we made a bad assumption there. And I don't know. What do you think? What does this group think? How did we get there? Why is this a new idea? Ma'am?
I think we forget the technology of time. In days you're talking about, information wasn't easy for people to get, and people had to take all their time to make a living. Whereas with the internet, information is widely available. How to integrate it is not known yet. Who knows what? So there is, again, a lot of danger in it being misused or aptly used. And I think that's what we sometimes forget when we don't look at the passage of history.
And I think that's wonderful. And Joe, right behind you, are we going that way? Okay, back to Max.
So I really loved your example of making doctors compete to lower costs by showing how they were doing compared to their fellows. I was curious if you saw any effects where the people who knew they were like the top 10% in keeping costs down started getting a little bit more lax about it because they knew they were already the best. So yeah, I just want to know if that happened, and if it did, how you might have offset it.
Yeah, that would be kind of was that the boomerang effect you referred to in your tweet? Yeah, and I appreciated that, and I'm glad to come back to it. We didn't see that so much as the physicians who rightfully stood up and said, I take on more complicated cases. My case mix index is more complicated, is the term. And so they said, my costs are going to necessarily be higher. And we said, okay, fine. We didn't penalize them for it. We just said we need to understand it. So that was okay. But we didn't see the opposite. We didn't see the creep from the bottom.
Great. We're going to wrap it up. So thank you to everyone on Twitter, and thank you to the audience here for your insightful questions and for staying alert. Thanks to Nick.
Thanks to Katie. Yeah. This is great.
Thanks so much for joining us tonight for this edition of Stanford Medicine X Live. We'll see you back here again on May 6th, 2014 at 5:30 p.m. Pacific Standard Time, when we'll discuss the topic Patient-Generated Data. Is it the future of healthcare? Moderated by Hugo Campos with a panel of physician and patient leaders. You won't want to miss this next episode of Stanford Medicine X Live. As a reminder, this program is made possible by support from the Stanford University School of Medicine, Department of Anesthesia, Stanford AIM Lab, Stanford Hospital and Clinics, and the Agency for Healthcare Research Quality. If you haven't yet done so, please take a moment to like our Facebook page at www.facebook.com/StanfordMedX so you can continue the conversation online and stay informed of program updates. From all of us here at Stanford Medicine X, we want to thank you for joining us today and remind you to join us again next Thursday, May 8th at 6 p.m. Pacific Standard Time for another edition of Stanford Medicine X Live, featuring a new healthcare design class from the Stanford University School of Medicine called Design for Health. Online activities are a great way for those of you in our class or at home to participate and join in the online conversation around Design for Health. Don't forget to join us on our Tumblr page and participate in this week's online activity involving co-design. Repeat the prototype process you did last week, but this time involve the person you interviewed during week 2. Get them to help you build something or refine your idea. Write about it or make a video of that experience and share it with us on our Tumblr page. Also, please don't forget that registration for Medicine X 2014 is now open. Don't miss the year's premier patient-centered conference on emerging technology and medicine. Unique opportunities such as our masterclass program and our IDEO Design Challenge workshop have extremely limited space availability. Regular registration is now open until July 31st, 2014. For all of you out there taking time to tune in with us tonight, thank you for joining us and being part of the conversation. A special thanks to our speakers this evening. From all of us at Stanford Medicine X, we'll see you next time.